So thank you again for such a kind introduction. So I'm very fortunate today to have four very qualified and talented people with me. So Dr. Amita Mahajan from Indraprastha Apollo in New Delhi, who needs no introduction. Dr. Siddharth Tutari from, let me pull up all of the list, and I apologize, Siddharth. We went straight from Sunil to us. Hold on one second. From CMC Vellore, Dr. Vandana Bhardwaj from St. John's Medical College in Bengaluru, and last but certainly not least, Dr. K.C. Anand, Sri Shankara Cancer Hospital, Bengaluru. So because we're relatively short on time, we will plunge straight into this discussion. We have basically picked four aspects of non-Hodgkin's, which most people think of as Burkitt's and MCP 842. And we want to just look at four different areas. So I'll let my four colleagues bring you up to speed on these four areas and some of the controversies in them. And I'll ask everybody involved to hold their questions to the end, but enter them in the chat box. So without further ado, I will see if I can go ahead and share my screen. One second, here we go. Okay, with apologies, it's, hold on. Part of the fun of Zoom meetings is you always have some interesting technical issue or the other.
Can I share your slides?
Sure, hold on one second. I'm going to share screen.
Okay.
And for some reason, it seems to, okay, allow, go to systems preferences. Okay, here we go. If not, Vasudha, I'm going to let you bring up the screen. Okay, here we go.
Yeah, we can see you, Dr. Kanwar.
Yeah, perfect. There was a privacy issue apparently. Why and how, I have no clue, but such is life. Okay. So going back one slide so that we have, here we go. So Dr. Anand, Dr. Siddharth, Dr. Vandana, Dr. Amita. So starting off with Dr. Anand, please go ahead.
Hi, good morning.
You have the stage. So Dr. Anand is going to take us through what changes there are in staging, how PET-CT might or might not affect these changes in staging, whether interim response has a role or not yet in non-Hodgkin's lymphoma, and whether PET-CT in general is being used or misused in pediatric NHL. So go ahead, Anand.
Yeah, hi. So we all know that with the major difference from adult NHL, pediatric NHLs are staged conventionally using St. Jude's modified Murphy staging, and this is in use for last 40 years. So I have put a picture of the staging system as well. But although it is very easy and convenient to use in pediatric in non-Hodgkin's lymphoma, it comes with a lot of limitations as it's a 40-year-old, and when it was used initially, only Burkitt lymphoma and lymphoblastic lymphoma was taken into consideration. But now in the last 40 years, with the advance into the science and technology, we have more and more subtypes including ALCL and PMBCL and other things. So these subtypes were not addressed in the original staging system. Also, St. Jude's system, it lacked the information on staging of particular sites, like especially bone involvement, skin involvement, and other organs. So any patients who are having this involvement of these organs were properly not represented or probably not recognized in the staging when we are mentioning the stage. Also, now we have more availability of more sensitive techniques for the involvement of bone marrow, CSF, or other organs with availability of flow cytometry or a PCR and PET scans. So with these limitations, with a group of experts from pediatric NHL, managing pediatric NHL, have proposed this new classification system, which is called International Pediatric NHL Staging System. It was published in 2015. There are many changes in it. What the major ones are: first, it addresses the involvement of multiple organs which are not addressed in the previous staging system, namely bone, skin, ovary, and lungs. Hence, now we can describe the disease site involvement accurately. And previously, in the older staging system, extranodal involvement on same side of the diaphragm was staged as stage 2, and extranodal involvement on both sides of the diaphragm was staged as stage 3. But in the newer staging system, 2 or more external involvement, irrespective of the side of diaphragm, is staged as stage 3. Also, previously, any involvement of bone marrow with the presence of any atypical cell on a bone marrow aspiration or a bone marrow biopsy was considered as stage 4. But in the current staging system, any bone marrow involvement less than 5% of the leukemic cells or blasts is considered as stage 3. Hence, it avoids some of the overstaging and possible overtreatment in some of these patients. Next slide. So, in one of the Italian studies, they retrospectively restaged patients on St. Jude's and in a newer staging system. And this is the comparative graph. So in stage 1, which is down, there was no change in the stage coming in both stage. St. Jude's is the older staging system is in the black, and the newer staging in the gray columns. So in stage 4, as the bone marrow criteria for bone marrow involvement is changed, there has been a decrease in the number of stage 4 patients. And in stage 2, there has been decrease in the number of stage 2 patients because, as I already informed regarding the external involvement, only the number of cases in stage 3 was more. So with this background, the current pediatric NHL staging is done by using, apart from the local staging, the staging in the for dissemination is done by using contrast enhanced CT scan, bone marrow aspirate and biopsy, and CSF analysis. These are the recommendations and time-tested modalities. So, but in the this current International Pediatric NHL staging system cautions the use of PET scan for staging in pediatric NHL because we don't have sufficient data, and because it changes the staging in various patients, probably changing the treatment in around 10% of the patients. So, as we don't have the data, they cautions. But they recommends, if it's available PET scan, we can use it for making the PET scan for staging. And but they also cautions the use of PET scan for making any form of treatment changes at this point of time. Next slide, please. Yeah. So in response assessment, also most of the studies, including the recently published international Inter-Retux BNHL study, they recommend to do PET scan only if it's available, and it has to be done baseline as well as for interim assessment and end of the treatment. But they cautions again against making any form of treatment changes with only PET scan reports. And we know conventionally we are using clinical assessment and other imaging modalities for response assessment. But there is one particular clinical scenario where we would use PET scan routinely, and it's important. And this is one of the studies from St. Jude's headed by Deepa Bhojwani. So for the evaluation of residual tumors to differentiate between fibrosis and residual disease, PET scan was compared with FDG PET scan was compared with conventional imaging contrast enhanced scan. So with the use of PET scan, the sensitivity jumped from 75% to 100%, and the specificity was also more. With most importantly, the negative predictive value of 100%, which means that virtually you can rule out all fibrosis cases with doing PET scan and avoiding biopsy and treatment. So it's one scenario where we can definitely consider using a PET scan. Of course, it comes with a caveat that you have to do a baseline scan along with the interim scan. For next slide, please. So for surveillance in pediatric NHL post-treatment, clinical assessment and CBC is the standard of care, and we all know that more than 3/4 of the cases of all relapses of the malignancies of NHL, we can do we can pick it up by only clinical examination alone and with some biochemical markers. And there is no advantage of using routine surveillance with any CT or PET scan imaging. Also, it comes with a disadvantage that it increases the cost of the surveillance. Also, it will lead to the more exposure of ionizing radiation with the PET or a CT scan, and also it comes with the psychological issues with the parents and the children. So currently for surveillance, no routine indication for any form of imaging in pediatric NHL.
May I start presenting?
Yep. This is where we change over.
Yeah.
So Siddharth, please go ahead.
So the topic given to me is rituximab from an LMIC perspective. So why do we talk about rituximab in pediatric NHL, that is the high-grade B lymphomas? Already rituximab is standard of care in adult high-grade B lymphomas, and more than 98% of pediatric high-grade B lymphomas, which include Burkitt's, diffuse large B-cell and primary mediastinal B-cell lymphomas, express CD20. Already Dr. Sunil has elegantly talked about the mechanisms of action of monoclonal antibodies. So what we see is when we risk stratify Burkitt's and DLBCLs based on elevated LDH more than 500 and stage 4 disease, that is based on bone marrow and CNS involvement, higher the risk group, lesser is the survival. And another reason is that we know that the first time we treat is the best effort to treat a B lymphoma, because once they relapse, it is really difficult to salvage them, and we know that the survival rates of relapsed B lymphomas is quite abysmal. So we need something to really increase the survival with frontline therapy, and the possible answer was rituximab. So next slide. So a landmark trial was conducted. So the countries across the Atlantic Ocean came together, performed a trial, a phase 3 randomized trial, which compared rituximab added to the LMB96 backbone versus the LMB96 backbone without rituximab. So the trial showed a remarkable improvement in the event-free survival at 1 year, which actually made the investigators to stop the randomization, and that improved survival in the EFS was maintained even at the end of 3 years, which one would expect because most of the events such as relapse and progression occur quite early in B lymphomas, usually within 1 year of completion of therapy. Next slide, please. And in the BFM backbone, which is the other trial which has addressed treatment of mature B lymphomas in children, we don't have such big data, but still small studies have replicated the improvement in EFS with the addition of rituximab. Next slide, please. However, there is a caveat. Although rituximab appears attractive, that it does not cause myelosuppression, it causes profound immunosuppression. Within 48 hours of infusion of rituximab, all the circulating CD20 positive cells of the body are depleted, and it takes up to 6 to 9 months for the immunoglobulin levels to really, for the B cells to actually reconstitute. So if we see the toxicity data of this trial, there were only 3 deaths in both the arms. But what is to be noted is almost all the deaths were in the group C patients, which had the maximum intensity of therapy. I'll come back to this in a moment. And we should note that if we compare the infections after the pre-phase treatment, which does not have rituximab in both the arms, we can see that there was a greater risk of infections in the patients who received rituximab. So the blue color shows the rituximab arm. Sorry, the previous slide, just a second. Yeah, and another important finding of the trial was that there was significant hypogammaglobulinemia at the end of 1 year. Next slide. So the trial seemed to show that rituximab is a really, really remarkable drug which can improve the survival. But recently, Tata Memorial from Mumbai published a study which showed quite alarming findings. We can see that there was significantly greater febrile neutropenia, pneumonia, intensive care requirement, and toxic mortality in patients with NHL who were receiving rituximab when compared to chemotherapy. And in fact, the study concluded that the event-free survival is inferior in children receiving rituximab with chemotherapy. And even after excluding the treatment-related mortality, the relapse-free survival did not show any benefit with the addition of rituximab. However, we need to take this study with just a pinch of salt because the backbone of chemotherapy in this study was quite heterogeneous. A lot of patients also received the MCP 842 protocol, which is quite different in intensity from the LMB backbone. And this is not a randomized study, it was a retrospective design. And another very important thing to know, which I showed in the previous slide, in this study, a lot of patients in the Ritux arm received the group C therapy, which is quite intensive compared to the non-Ritux arm, where a lot of them called the MCP chemotherapy, which is quite less intensive. Next slide, please. So putting all this together, what is my take is rituximab, we cannot go away from the randomized data that rituximab improves survival. Okay, but we need to remember that it causes additive immunosuppression, and whenever we follow protocols which are designed in the West, we should try to adapt them rather than verbatim adopting them, because we do face a lot of peculiar issues like social disparity, malnutrition, and increased infections. But we know that supportive care in our country has improved leaps and bounds in the last decade, and therefore we should still keep rituximab as an option for our high-risk mature B lymphomas, and try to add rituximab wherever it is feasible. And one thing which we follow at our center is we give IVIG infusion after each cycle of chemotherapy. Now, whether that would decrease the infectious morbidity and mortality, prospective studies would have to answer that question. And another important thing is, which trial is addressing right now, the Reboot Ably trial, is that whether the addition of rituximab can decrease the intensity of the cytotoxic therapy, like decrease in the doses of anthracyclines, and this could contribute to a reduction in the infectious morbidity and mortality. Last slide, please. And finally, I just want to touch upon PMBCL, which is kind of a different type of lymphoma from the other two modalities. The survival still remains suboptimal despite giving the conventional chemotherapy. And although an initial study from the BFM group of 15 patients showed a very good survival, the dose-adjusted epoch backbone with rituximab added, this same intergroup trial, which did a single-arm study of the same chemotherapy in PMBCL, did not show an improvement in outcome. And therefore, we really need to see if any novel agents, which probably Dr. Amita would talk about, might improve the survival in this group of patients. Thank you.
So thank you for a very erudite and illuminating review of rituximab. So we're going to switch from PET and rituximab to something that's a little even equally, I would say, uncommon, but which, when we all encounter it, causes all of us issues. So ALCL relapse. Dr. Vandana Bhardwaj will be talking about this. So go ahead, Vandana.
Thank you, Dr. Kanwar, and thank you, Vasudha, for the opportunity to speak at this forum. So ALCL, as we all know, is imminently curable. It constitutes 1 to 2% of all cancers in children. The upfront treatment, as established by various groups, the BFM group, the COG group, by different protocols, offers 65 to 75% event-free and overall survival by multi-agent chemotherapy. ALK positive patients do better than ALK negative patients. And luckily for us as pediatric oncologists, 90% of children have ALK positive disease. We also know that relapse patients are chemosensitive, behave sometimes like Hodgkin's lymphoma, perhaps due to their CD30 positivity. So looking at the options, so vinblastine has been studied as a single agent in low dose for long duration, so something like a metronomic chemotherapy. And the French experience, and I've quoted the reference there, gave an event-free survival of about 30% and overall survival of 65%, suggesting that even after relapse from vinblastine, these patients remain chemosensitive and can be salvaged. So vinblastine was explored as backbone to the chemotherapy in both the BFM as well as in the ALCL19 protocols, and it is now being explored as upfront therapy option for low-risk patients, so that they are spared the not only the acute toxicity but also the long-term side effects of combination chemotherapy, including that of anthracyclines. Next slide, please. So stem cell transplant. So we all know that particularly in the B lymphomas, we do opt for stem cell transplant, perhaps in CR2 as a salvage, as a consolidation chemotherapy. However, in ALCL, there is no consensus on the merit of stem cell transplant. The BFM group as well as the Japanese showed that the relapse after an autologous stem cell transplant was similar to that of patients that were treated on chemotherapy alone at relapse without a transplant. And some groups have explored allogeneic stem cell transplant and have found that they may be of benefit to high-risk patients, i.e. multiply relapsed patients. But the numbers are small, so 10, 8, and these groups have showed that radiotherapy-based conditioning was beneficial to these patients. So I'm not sure that stem cell transplant can be offered directly to these patients because the salvage is not so good. The other two exciting drugs that are out there now for us to think about are ALK inhibitors. So crizotinib is the first prototype of this category and is used extensively for non-small cell lung carcinoma in adults. So I've the reference there from the COG group of 26 patients in relapsed refractory ALCL and given doses of 165 or 280 milligram per meter square orally, and the overall response rate was 80 to 90%. So it's really promising in terms of response rate, but whether it will actually offer long-term salvage as a single agent is not clear. So combination with chemotherapy backbone upfront for high-risk patients is something that some trials are currently exploring, and we need to wait for the results of these to make up our minds about it. Next slide, please. Final thing is about anti-CD30. Brentuximab, of course, has gained a lot of popularity both in adult as well as pediatric oncology world, lymphoma world. So it's an anti-CD30 monoclonal, as we all know. So given, trialed in this in this European study, 1.4 or 1.8 milligram per kilogram intravenously every 21 days, but given over a long period of time. So there were 17 patients on this study, an overall response rate of about 53%. However, brentuximab does come with its problems, causes significant hematological and neurotoxicity in about 30% of patients. So brentuximab alone as a long-term probably not feasible in our country, particularly because the cost is fairly steep. So using a couple of cycles of brentuximab as a bridge to stem cell transplant is a possibility.
So at this point, it's Vandana, thank you again for such a wonderful summary of anaplastic large cell and the different modalities which can be used for this very frustrating condition. So I'm going to switch over to Amita at this point, who is going to give us a very brief overview of novel agents and what else may be becoming available to us in the field of pediatric NHL in the next few years. So Amita, it's all yours.
Yeah, thank you, Vikram. Thank you, Vasudha. And I'd like to congratulate Vasudha on putting together a very elegant program that I've really enjoyed listening to. You'll all agree that pediatric NHL, by and large, where optimal treatment is feasible, the outcomes are fairly excellent. So much of what is happening in NHL and in future strategies really comes from adult data, because there is a large cohort of relapsed refractory DLBCL, and also they have subgroups of patients who are actually may not be fit for very intensive chemotherapy. So which of those approaches in the times to come will be applicable to pediatric NHL? I'll just go very briefly over that in the next few minutes. So like I said, the novel approaches are really needed for the small proportion of refractory or relapsed disease. But yes, if we have approaches that are much less toxic, we could perhaps look at optimizing treatment by limiting, short-term toxicity. Like Siddharth has just pointed out, that combining rituximab with Group C regimen of LMB kind of strategy is really very intensive for most centers in India. So one of the areas of interest has been the checkpoint inhibitors, with very impressive outcomes in Hodgkin lymphoma, even in children. So this is actually the one strategy that we do have some, albeit limited experience with. And at least in the adult world, the checkpoint inhibitors have really moved into frontline therapy for a large number of indications because of limited toxicity, in contrast to some of the other immunotherapeutic approaches. The challenge with NHL though is that the PDL expression is fairly limited in most variants of NHL. And NHL is not one disease, it's many diseases. But one of the conditions within that group that actually has significant PDL1 expression is actually primary mediastinal B-cell lymphoma. So at least in the pediatric world, this is where the approaches are being looked at. In the adult world, checkpoint inhibitors have been evaluated in virtually all categories of relapsed refractory disease. But for the pediatric age group, the most promising candidates seem to be primary mediastinal B-cell lymphoma. And there is a current COG phase 3 study that is randomizing chemotherapy with or without pembrolizumab for this group. The other three categories that may benefit and ongoing trials, those small numbers are on, is primary CNS lymphoma, again a very rare entity in children, and post-transplant lymphoproliferative disease, especially if it is EBV driven, seems to be benefiting with the addition of checkpoint inhibitors. And some of these patients may be sick. They are already on a lot of immunosuppression, so that may be a promising kind of strategy for them. Another impressive, a category with impressive responses is NK T cell lymphoma. And again, rare entity in children, a small case series, but impressive outcomes shown with this strategy. Next slide. So another group that one is looking at, rituximab has transformed the treatment of the NHL and, like we said, has improved outcomes for group C disease. And we are currently looking at whether addition of that may allow us to de-escalate the chemotherapy segment of treatment. Similarly, other monoclonal antibodies have been attempted for CD20 positive disease, but so far there is no evidence of improved outcomes, and I think this is going to be petered out because all of these patients would have actually received rituximab in the first go. A strategy that does seem to offer some promise is antibody drug conjugates. And within that, there are a number of them. I've chosen the two that we are a little bit more familiar with, brentuximab vedotin and inotuzumab ozogamicin. In the adult world, about 30% of DLBCL is CD30 positive, and that's why brentuximab vedotin is being tried in that group. And inotuzumab again is showing some impressive data, but the data is much better if they are combined with rituximab. So it doesn't look that in isolation they will be very promising, but when combined with rituximab, they may be promising, but hardly any data or anecdotal reports from the pediatric world. CAR T cells, especially KIMRA, this is the one that has been evaluated most extensively in this group. There is phase 2 data in adult relapsed refractory BNHL, and early pediatric trials are ongoing. And almost certainly this may be promising in the time to come, like it is going to be for refractory ALL or relapsed ALL in children. In the adult world, what data is there shows about 40% a CR rate for relapsed refractory disease, of which about 75% continue to stay in long-term remission. So this is something when it does become available for ALL that one may consider that. And again, it is mostly the CD19 CAR T cells, but there are other CARs that are currently being evaluated. Next slide, please, Vikram. I think there is another.
Was there one more slide? I apologize. One second.
So there are other agents that are the targeted therapies that are being evaluated, which includes agents like bortezomib, ibrutinib, everolimus, things that we do have access to. But again, they are being applicable to very small subsets. The problem is that pediatric NHL, especially when we filter it down to the relapsed refractory group, almost every patient has an individual type of disease. So any data in pediatrics, it will take a long time to filter through to us. Very limited trials are ongoing because we will, to really do a successful trial, very large multinational collaborations will have to take this on. Otherwise, we'd just be, applying or adapting whatever we get from the adult world. So some interesting options there. And I think in the years to come, we will learn more about them. That's all from me, Vikram.
Yep, no, that is really the end. I apologize. I think a C- for slide changing. Hold on one second.
That's okay.
Let me get out of
No,
this.
I think you helped us to get the messages across, so that should be all right.
Well, let's see if we have a few moments, if they'll give us a few moments to bring in all of the speakers. And basically, I think at the end of the day, let me see if there are questions. So, okay, there's one question from Dr. Anand, which I think Siddharth had partially answered with regards to reduced chemotherapy use. So I guess what I'll ask at this point, I don't know if I can bring up all the speakers together in one. Yep, I can. Okay. Because I feel bad just talking over everybody. Everybody's done all the hard work, but I'm just here enjoying the fruits of their labor, like a typical capitalist. So in general, if you had to give a one sentence summary, I think I'll address this back to Dr. Anand and say, if you work at a center where you don't have access to PET-CT at all, and you're treating pediatric NHL, does it make any difference at all?
No.
And that's a yes or no kind of answer, but
No.
you can, I don't know if everybody is everybody on with their speakers?
Anand, can you be a little louder, please?
Yeah. I don't think it doesn't matter even if its PET-CT is not available.
I mean, to me, that's the bottom line, because there are so many private PET-CT stores and everybody is soliciting all of these patients, and to do children require sedation or anesthesia sometimes with small children. But I think we need to realize PET-CT is a modality in evolution. Coming back to rituximab for Siddharth. So I guess the other question is rituximab is also in flux. If you work at a center which doesn't have access to rituximab, how much does it impact the short-term care of your patients?
Rituximab, actually, even though the trial has shown the benefit, our center started using it only in the last 1 year. So I really don't think in the absence of rituximab, it would be a huge change. We can still salvage a significant proportion of patients with the conventional chemotherapy with good supportive care.
Right. I think basically there's like about 10 to 15% disease-free survival. If you can afford it, it's great. If you can't, then at the end of the day, you're still going to, in group A and B, at least get about 80+% of your patients with good supportive care. Coming back to Vandana, so for anaplastic large cell lymphoma, if she's still here.
Yes, I am.
Oh, she's here. Okay, good. Yeah. So again, what is the cost of crizotinib in the Indian setting?
I must confess, I don't know actually.
The folks from Tata will know, Siddharth, because we get a formulary and cost to go with that. How much does crizotinib cost a patient if we use it? Amita, maybe, have you had to experience
So
that?
it will be, I've used it in 2 patients and they were younger. So one was a neuroblast and the cost was about $1 lakh per month for them.
Right.
The problem is, for how long does one give it? That is if you're for a if we knew exact duration, we can counsel families accordingly. So that is the challenge, I think.
This is the challenge for anaplastic large cell. I hate them. People always say this highly curable. I've had many patients who end up refractory and they go into remission with vinblastine. Then how long do you keep bringing them back for? How long do you treat them for? It's a horrible disease. Luckily we don't see that much of it. And Amita, you get to say the last word, which is appropriate and fair.
So I think in the novel therapies, if we do have relapse refractory disease, I think we have to look at what is available out there for that very, very specific type of lymphoma. Like, for example, I have treated 2 NK T cell lymphomas with pembrolizumab, and one had virtually no response, a very transient response. And the second one has done brilliantly. So, for previously we would have, we have anyway very limited experience with these sort of diseases. So I think we are now, like in the adult world, have to really, bottle down to what is the disease, what is available out there, can my patient actually have access to it, and then give it a go. And, that's how we are going to build up our experience. I don't foresee us developing studies, related to them, because they will remain rarities for us.
Agreed. So, Vasudha, at this point, I'll thank you greatly.
Dr. Kanwar,
allow me to go over time.
There are a couple of more questions from Dr. Manas Kalra.
Oh, please go ahead.
Want to take it. So he asked that, if you don't do a PET scan, you may end up biopsying more residual masses.
Do you agree or disagree with that? I'm going to toss that back to the whole panel and say, do you agree with that or disagree with that? You get to vote, yes or no.
Probably will end up with more biopsies.
Why?
Because in the evaluation, response evaluation by CT scan, it has to be CR. The disease should be completely absent to not say residual disease. So any residual disease, if they are, even if it's fibrotic tissue or dead tissue, it has to be biopsied if we are doing only CT scan.
So in other words, in order to avoid biopsying your residual mass, basically a PET CT is an alternative to that.
Yes.
Because it has good negative predictive value.
Negative
So
predictive
that's one place you can use it. Yeah, and probably for then you need to have an initial scan in order to compare it.
Yes.
So you actually know what you're looking at. So I think that's a very reasonable comment, very reasonable feedback.
I think there is some data coming in from UK where they have actually biopsied all the residuals, and but they're going to present it soon as to which one are really viable and which ones were actually.
That's very interesting because many of these are not viable. That's part of the challenge. That's part of the issue we all face. Okay. Any other questions you can see?
Siddharth has answered to the second question on the chat box. Thank you, Dr. Siddharth. Thank you, everyone, for that really amazing and stimulating panel discussion. Thank you, Dr. Amita, Dr. Vandana, Dr. Siddharth, and Dr. Anand. It was a really interesting discussion. And thank you so much, Dr. Kanwar, for putting it all together.
Well, they did all the hard work, and you did all the hard work in this conference. So I do thank everybody. And I ask you to smile. Siddharth, smile. Like, I've had my coffee, you haven't, I apologize. Okay, take care, everybody.
Thank you.
Next session.